I will just give an overview of what I'll be going through today. So I'll just give a background of what hemoglobinopathies are, the various, a brief note about the various methods which are used for detection of hemoglobin variants before proceeding on to discuss HPLC, hemoglobin HPLC in detail, and what are the limitations of hemoglobin HPLC. Everyone can just type in their questions in the chat box. I'll try to answer them at the end of this talk. So starting off with the basics of the hemoglobin molecule, which is the adult hemoglobin molecule is composed of 2 alpha chains and 2 beta chains centered around the heme molecule. So in adults, majority of the hemoglobin is hemoglobin A, which is alpha 2 and beta 2. With minor proportions of hemoglobin A2 and F. And this switch to the adult form of distribution of hemoglobin is complete, almost nearly complete by the age of 1 year. And the globin gene clusters, these are present on chromosome 11 and 16 towards the telomeric end. The 11 chromosome has the gene cluster which is composed of the gamma gene, the delta and the beta gene clusters, which comprise of mainly the adult and the fetal hemoglobin. Whereas the chromosome 16 has both the alpha genes. There are 2 alpha genes along with the embryonal globin chain molecules. So this is just an overview. This most of you must be aware of by now. I just wanted to give an overview before going into the other details. So the term hemoglobinopathy usually is used to encompass all the quantitative as well as the qualitative defects in the hemoglobin molecule. However, it is more prudent to use the term hemoglobinopathy only for the structural variants, that is the abnormal hemoglobin variants. So the hemoglobinopathy should ideally be restricted, the terminology should ideally be restricted to only the structural variants of hemoglobin. These can be variants in the alpha, beta, delta, as well as the gamma chains. Whereas the term thalassemia usually denotes a quantitative defect of a structurally normal hemoglobin globin gene molecules. These are alpha, beta, delta, and the other thalassemias. So thalassemia is usually a quantitative defect in a structurally normal globin gene, whereas hemoglobinopathy should usually be used to restrict it to the denote abnormal hemoglobin variants. Whereas in between you have the hereditary persistence of fetal hemoglobin, and then you have something called as thalassemic hemoglobin variants, or also known as thalassemic hemoglobinopathies. So these are quantitative defects in structurally abnormal globin chains. So the examples are hemoglobin constant spin, hemoglobin LEPOR, and hemoglobin E. So in these particular hemoglobin variants, there is a structural defect in the globin genes, which causes them to degrade within circulation. So whenever you detect them by any method, in heterozygous conditions, usually you don't find them to almost 50%. So usually in heterozygous conditions, you should find the quantity of these hemoglobins should be around 50%. That's what you would expect, but that does not happen because they degrade in circulation, giving rise to lower percentages when you detect them. That's why they call as thalassemic hemoglobinopathies. I hope that's clear to everyone. So thalassemias are quantitative defects, qualitative defects, and hemoglobinopathies. A combination of both is thalassemic hemoglobinopathy. So to detect these particular variants, we use different methods to identify the patterns, which will be either electrophoretic methods or HPLC or capillary electrophoresis. And to quantify them, the quantification is usually done by HPLC and capillary electrophoresis. In the case of HPF, you can use alkali denaturation or clear test to quantitate the hemoglobin F which is present. So this is about the different methods. I'll just start off, give a brief overview of the electrophoretic methods, starting with the simplest one, which is the gel electrophoresis. In this, the hemolysate, which is prepared from EDTA anticoagulated blood, this is loaded onto cellulose acetate gel, which is at an alkaline pH, usually around 8.4. It can range from 8.2 to 8.6. So the hemolysate is added onto these gels towards a negative electrode, and when a current is applied across this gel, there is movement of hemoglobin, various hemoglobin molecules present in the sample towards the positive electrode. So at this alkaline pH, the adult hemoglobin moves the farthest towards the positive electrode. You can see here that this is the adult hemoglobin band. So various amino acid substitutions which occur in the globin genes, they alter the charge which is present on the hemoglobin molecule, thereby altering the velocity which they travel through the gel. So a normal adult hemoglobin travels the farthest, followed by fetal hemoglobin. Then you have two separate lanes for sickle cell hemoglobin and hemoglobin A2. So whenever you run a gel, there has to be a control lane which contains all these four different hemoglobin molecules. So starting from farthest away from the origin, you have A, F, S, and C. The C lane has hemoglobin A2, hemoglobin C, hemoglobin E, and hemoglobin O. All these come in the same lane. They have the same electrophoretic mobility. That's why they come in the same lane. Similarly, with the hemoglobin S, you have hemoglobin D and hemoglobin G coming along with the same hemoglobin S molecule. So this is about the gel electrophoresis. This is a very simple method. And usually we run at an alkaline pH. That's the first gel electrophoresis which you run. In cases where there is a single band present within the S or the C region, you need to separate it whether they're homozygous or compound heterozygous states. We would have to run an alkaline electrophoresis. That is, as I mentioned, that they may have same velocity and migrate together. So we'll have to run an acid electrophoresis that is done using a citrate agar at a pH of around 6. So the utility of running the second gel is to separate hemoglobin C, which separates out in the, as you can see that hemoglobin C is able to separate out from the other variants in a acidic gel electrophoresis. Similarly with S also, you can easily separate S from D or G using an acid electrophoresis. So this is a very basic method for identifying the different normal hemoglobin variants which are present within a sample. However, this can be used in smaller laboratories and does not require any expensive equipment and is simple to perform. But the limitations are that it is slow, it is labor intensive, and it is a qualitative technique. You cannot quantify accurately low concentrations of hemoglobin as well as certain fast moving variants, that is hemoglobin H and BARTs. So the electrophoresis method has largely been superseded by the HPLC in most laboratories. However, some laboratories still use hemoglobin electrophoresis, gel electrophoresis to diagnose variants, but you cannot quantitate them. So sometimes you might be getting requests from clinicians who use hemoglobin electrophoresis as interchangeably with HPLC. So that's incorrect. So ideally, you should specify what methodology you're using for hemoglobin variant analysis, whether it is electrophoresis or HPLC. So there are two different techniques. So this is one electrophoretic method. Then you have another electrophoretic method, which is known as the isoelectric focusing. Here the gel contains a pH gradient itself. So when these hemoglobin hemolyzed sample is applied to this gel, and whenever the hemoglobin proteins migrate across this field, when they encounter an isoelectric point, there is no net charge at isoelectric point and they stop migrating. So the pattern of the electrophoresis in isoelectric focusing is similar to alkaline electrophoresis. This is the representative gel which you can see on top, but this has better resolution compared to the alkaline gel electrophoresis. So we can run, another advantage is that we can run many more samples in isoelectric focusing. However, it requires experienced staff and there are many other drawbacks to this method. So this is also not largely used by labs. So it's mainly employed in newborn screening programs to detect S or C variants. The other more advanced electrophoretic method is the capillary zone electrophoresis. Here, small glass capillary tubes are employed which are filled with buffer. And so employing these small gas capillary tubes helps us to process a large number of samples at the same run. And when an electric current is applied across these glass capillary tubes, the hemoglobin molecules separate based on their electrophoretic mobility. So this is a fully automated method, and it gives high resolution separation of the different variants and also gives direct quantification. So this is the only electrophoretic method which is able to give you a quantitative number to the different normal and abnormal fractions compared to the previous two, which are qualitative only, will just give you a band. Although you can use densitometric tracing to give you a semi-quantitative analysis, but those are not accurate. So those were all the electrophoretic methods. Now we'll go into detail about the topic of the day, which is HPLC. What exactly HPLC is, and also a few representative cases and what you should keep in mind when you're reporting HPLC chromatograms. So starting with the principle of the HPLC, the methodology which is used for hemoglobin HPLC is the cation exchange HPLC or CE-HPLC. Here the analytical cartridge or the HPLC column which is used. This is a representative photo of the HPLC column. Excuse me, this contains negatively charged silica particles. That is nothing but the stationary phase. Then you have the mobile phase, which is the liquid phase that contains the buffer and the hemolysate. So the buffer in the hemoglobin HPLC contains sodium and potassium ions. The hemoglobin molecule which is present in the hemolysate is positively charged, whereas the silica is negatively charged. So when along with the buffer, this hemolysate is made to pass through this HPLC column, the hemoglobin molecule interact with the silica. So there is an interaction between the positively charged hemoglobin molecule and the negatively charged silica. So depending on the concentration of the sodium and potassium ions within the buffer, as well as the charge on the molecule, which is determined by the structure of the hemoglobin chains and the globin chains, the interaction may be less or more between the silica particles. So if there is less interaction between the particular variant with the silica column, it comes out faster outside the machine. So the time spent within the HPLC column is known as the retention time. That is a T1. How much time the particular hemoglobin variant molecule, that could be adult hemoglobin, fetal hemoglobin, or the other abnormal hemoglobins, the time they spend within this column is known as the retention time. So if depending on their structure of the globin chains, the interaction may be more. So they may take more time to come out of the HPLC column. So the retention time will be longer. Also, the differences between the different components of hemoglobin variants which is present within the sample, there can be good separation or not so good separation depending on, again, on the structure of the globin chains. So when you get a chromatogram output which is detected by the detector, you get it in the form of different peaks. So as they come out, flow out of this HPLC column, they are detected by the recorder, which plots these particular peaks against time, which is nothing but the retention time. So this is about the principle of the HPLC, hemoglobin HPLC, which is the cation exchange HPLC. So cation exchange HPLC allows for automated sampling, as well as it has the advantage of measuring small quantities of hemoglobin F and A2 compared to the gel electrophoresis methods, which is the inferior compared to the HPLC. Another added advantage is that the HPLC, hemoglobin HPLC, can be used for glycated hemoglobin. That is the gold standard method for detection of glycated hemoglobin for monitoring of diabetes. So the two common machines which are used in most laboratories is by BioRad, which is the BioRad variant 2, as well as the BioRad D10. So the BioRad variant 2 is a more specialized machine, which is designed specifically for detection of variant hemoglobins, whereas the D10 is machine can do both HbA1c detection as well as variant hemoglobin analysis. So some laboratories, the smaller laboratories, would be having the D10 machine, whereas the more specialized laboratories may be having variant 2. Both are okay for diagnosis of hemoglobinopathies using HPLC. Apart from BioRad, you have machines from Torso, Menarini, and Primus, which also give similar results. It's just that the resolution and of the peaks and other things are different. We'll come to that later in the subsequent slides. So what the basics of HPLC chromatogram, as I mentioned, that the as the hemoglobin molecules are coming out of the HPLC column, they're detected by the detector, which plots it on a time axis. That is nothing but the retention time. So that retention time is derived from the median of the peak. So wherever the peak is there, that is the retention time of that particular peak. Then the proportion of the hemoglobin variant is determined by the area under the curve. So that will give you the percentage of the particular variant out of the total hemoglobin. So what are we supposed to check whenever we are reviewing HPLC chromatogram is that the baseline is straight and properly constructed, and the peaks are symmetrical and sharp, and the total area, which is, I'll show what total area is in the subsequent slides, that is between 1 to 3 million. This is for the Biorad variant 2. This range is 1 to 4 million in the Biorad D10 machine. So that's like an internal QC check. While interpreting, what are we supposed to note in the HPLC chromatogram? We are supposed to check the retention time of the various peaks, how much proportion of total hemoglobin that particular peak is, and the peak characteristics. That is whether the peak is broad, sharp, and various other things which you can note in peaks. Those are the things which you should note in a HPLC chromatogram. So we're supposed to note the retention time, proportion of the variant, and the peak characteristics. So before doing HPLC, it is important to know a little bit about clinical background and CBC data, because these will impact your interpretation. So the important things we should know in the clinical details is the age of the patient, because the reference ranges for F and A2 are age dependent below 1 year of age. What was the indication for doing HPLC, whether it was for antenatal screening, diagnosis of anemia, or any prothrombotic state such as sickle cell hemoglobin. History of transfusions, how many transfusions, when was the last date, because this is going to alter the proportion of various hemoglobin variants which you're going to get. If there was a history of a recent transfusion, you might get falsely low levels of abnormal variants with a larger fraction of adult hemoglobin which has come from transfused blood, and any other history of jaundice or organomegaly which is present in the patient. Along with this, whenever HPLC is done, it is better to run CBC on the same sample. For your own, if CBC is not available, it is better to run CBC on the same anticoagulated blood for your reference. This helps in interpretation many a times. So the minimum data which should be available are hemoglobin, red cell indices, and reticulocyte count. In certain cases where there is a doubt, parental CBCs or HPLCs may be required. So the data, as I mentioned, what should be noted? You should look at the numerical data, unknown peaks, the peaks which are F and A2, and then you have P3 and P2 peaks. These are what you're supposed to know. Then you're supposed to look at different windows within these windows are determined by the software which is present within the machine and the chromatogram. So the total area should be 1 to 3 million. This is the particular total area, this is the variant 2 or calibrator output. And you can see that the total area here is between 1 to 3 million. So this is acceptable for interpretation. And when you're running a calibrator, you should check that whether the calibration factor is between 0.8 to 1.2. You can see that here the calibration has passed. And whether the A2 retention time is 3.65 plus or minus 0.1. The linearity for the variant 2 machine is 1 to 13% for A2 and 1 to 40% for F. So these are the low control and the high control output data for the variant 2 machine. So in the low control, you can see that the low values for F and A2. So these are all provided by they should match with the manufacturer provided range. So the same low control and high control are provided for the D10 and should match with the manufacturer's reportable range before you run your other samples. So the manufacturer says that before every run, a calibrator, a low control and a high control has to be run. And these act as internal quality control checks before you run your test samples. So these are the manufacturer given retention times or windows which are programmed into the machine. So first you have the whatever first peak is the hemoglobin F peak, that is 1.1 retention time. This was variant 2. These retention times might be slightly different for Bioride D10 machine. Those retention times are available at their website. You can check them out. So the whatever is present before 1 minute time is known as a pre-integration region or the pre-integration part. So the machine does not provide you tabulated data for that particular area. So as you can see here, whatever is before 1 minute, the machine does not provide you any tabulated data in the output. So the total run length is for 6 minutes, and whatever is before 1 minute is known as the pre-integration region. So after F, you have the P2 and the P3 peaks, and then you have the adult hemoglobin, which is denoted as A0. Then you have the fractions of adult hemoglobin, which is hemoglobin A2. Then you have the different variant hemoglobin windows, which is the D window, S window, and the C window. So whatever abnormal hemoglobins, they come in these particular different windows, and there are differential diagnoses for variant peaks in each different window which you are able to get, which is given in this table. So in the P1 peak, that is the pre-integration region, the peaks which are usually noted are bilirubin, hemoglobin Barts, and hemoglobin H. These are present within the pre-integration region, that is below 1 minute. Next comes the hemoglobin F. In the in P2 region, the most important fraction, which is the glycated hemoglobin, comes here. HbA1c elutes out in the P2 region. Then in the P3, you have post-translational modified hemoglobin A. Another thing which you should know is that whenever all post-translational modification, that is glycated hemoglobins, carbamylated, acetylated hemoglobins, always come before the actual peak. So if the adult hemoglobin in HPLC, the modified products of adult hemoglobin will come before that. So if there was a variant peak, large variant peak in this region, for example, here you have a large variant peak. So the modified products of this particular variant peak might come in the A2 window. So you might get a false elevation of A2 just because of the presence of this particular variant here. So that is what is happening here, that in the P3 window, you have post-translationally modified hemoglobin A, which can increase with aging. So one way to detect whether you have received a very old sample is to look at the P3 window. If you have very high level of P3, then it might indicate that either it's a variant which is there over there, or that the sample is a very old sample. So it is prudent to repeat the HPLC with a fresh sample in that particular case. An important hemoglobin which elutes out in the P3 window is the hemoglobin J. Hemoglobin J Meerut in the context of India. So adult hemoglobin, you have this. Then you have the A2. Along with hemoglobin A2, you have quite a lot of significant hemoglobins which come along with A2 in the hemoglobin HPLC, which is hemoglobin E, hemoglobin Lepore, and hemoglobin D Iran. Then you have the D window where you have hemoglobin D Punjab. Hemoglobin S window, as the name suggests, that you have the hemoglobin S, and in the C window you have hemoglobin C and hemoglobin O. So just a Google search will give you this different set of different differential diagnosis for all the hemoglobins which come in the different windows. So this knowledge is useful. It's better to have this as a ready reference whenever you're interpreting HPLC chromatograms. There are different retention times as well as what could be the abnormal hemoglobin variants which are present in the different windows and the different peaks. Another knowledge about the different values of hemoglobin A2 and hemoglobin F is also important before you begin interpreting HPLC chromatograms. You should know that hemoglobin A2 is used for diagnosis of beta thalassemia trait. So usually the safe range to assume that the patient has beta thalassemia trait is 3.8 to 7. These tables are available in DAISY for reference. You can stick them up whenever in front of you whenever you're interpreting HPLCs. So normal is around 2.0 to 3.5. Low A2 levels are seen in case of alpha thalassemia trait, hemoglobin H disease, and in case of iron deficiency. So this is a very common problem in Indian population, that many patients have concomitant iron deficiency along with beta thalassemia trait. So that might cause false lowering of hemoglobin A2, which might cause problem in certain cases. So you might get borderline levels like this, where there is even iron deficiency in beta thalassemia trait. So in such cases, it is better to treat the nutritional deficiency and repeat the hemoglobin HPLC to confirm the diagnosis of beta thalassemia trait. Hemoglobin F levels up to 1% is normal. Anything between 1 to 5%, this can be seen in case of 30% cases of beta thal trait. Also in secondary disorders such as aplastic anemia, MDS, JMML, or in pregnant women, especially in second trimester. Occasional case of beta thalassemia trait can have F levels up to 20%. So this should not be misconstrued as some other variant or thalassemia major or intermediate. So you can have beta thal trait cases where hemoglobin F can be up to 20%. And then obviously you have the other beta thal major and hereditary persistent fetal hemoglobin, which are the differentials for very high hemoglobin F values. So this is just a comparison table between the variant 2 and the D10 machines. So the main differences is in the machine itself, where you have a computer and a clinical data management software which is attached to the variant 2, allowing the complete data backup. Whereas in the D10, it's just a touchscreen operation with an onboard software. There is just a thermal paper output. It is difficult to get a computer backup. As well as in the terms of interpretation, there is no D window in the D10. So the machine does not have a D window program. So if any hemoglobin D is present in the sample, it will just be detected as unknown as the machine. So you'll have to manually interpret it. Apart from that, the chromatogram, which is the output of variant 2, the peaks have better separation. There's better sensitivity for detection of F. Whereas in case of D10, it's the variant peaks are less well separated from each other. The throughput is also lesser compared to D10. So compared to the two machines, the superior machine is a variant 2 because that's more specific for detection of hemoglobinopathies compared to D10. So with this detailed overview of the HPLC principle and the procedures and what all you should know, I will just move on to certain different cases which are relevant in the Indian context. What are the things which you should know and how to interpret HPLC chromatograms. So Biorad has this useful online tool, which is the library of variants. So you can just go to their website and search for this on Google, and this is very helpful. And you can input whatever machine you have, only Biorad machine, and the program which you are running. So in this particular screenshot, I have set it as a D10 with a dual program, that is a beta thal detection program. And if you have any unknown peaks which are present, you can always input the retention time which is provided by the machine to find out what particular hemoglobin variant might be present, might come at that particular retention time. If you are unable to diagnose some unknown peaks, it's a difficult case, you can use the help of this particular resource. And I've used all the representative cases which I'm going to present. I've taken them from this particular website only, so that it's easier for you also. You can go and access this website and look at the different various representative cases. So starting off with the most common important one, that is the beta thalassemia. Just a minute, I'll just get it. Yeah, beta thalassemia trait. So this is a beta Biorad variant 2 output. So you can see that the A2 is elevated, that is 5.1%, clearly in the range of beta thalassemia trait. And as I mentioned earlier, that there might be occasional cases of beta thal trait where the hemoglobin F can be elevated. So in this case is 10.4. So we check the area, it is okay. We check the baseline, it is fine. And we look at the different peaks, they're symmetrical. So it is good for interpretation. So it's a case of beta thalassemia trait with microcytic hypochromic indices. So there can be some situations where the whole picture may not be classical of beta thalassemia trait. There may be cases where the MCV may be normal, red cell indices may be normal, but the A2 will be elevated. This can happen in case of co-inheritance with alpha thalassemia, or cases where there is borderline or normal hemoglobin A2 with a thalassemia like red cell indices. This can be in some mild beta thalassemia alleles, co-inheritance of delta thalassemia. Then there can be rare conditions where everything will be normal with borderline hemoglobin A2. This can happen with alpha gene triplications or very silent, mild or silent alleles. Or there might be situations where there is clinically significant anemia in case of beta thalassemia trait. That can be because of triplication of alpha genes or HPH disease present along with beta thalassemia trait. So these are some of the atypical presentations of beta thalassemia trait, which you should know whenever you are interpreting HPLCs. Moving on to the other common one, which is the beta thalassemia homozygous. So in this case, you can see that majority of the fraction is here is coming as hemoglobin F. So the machine is unable to detect hemoglobin F in the hemoglobin F window, but it is saying that it is an unknown peak, but this is nothing but hemoglobin F. So this kind of misalignment can happen with hemoglobin molecules which have a very broad base, that is hemoglobin F or hemoglobin D. However, this whole thing is hemoglobin F with A2 of 2.8%, and the patient has clinically significant anemia. So in such cases, it's very important to know the age of this patient. So if you told me that this particular case was from a 1-week-old child, 1-week-old baby, I would not be worried. That is normal for this particular HPLC chromatogram is normal for a 1-week-old child. But if it was a 8-year-old child coming with this HPLC, then it is nothing but beta thalassemia major or homozygous beta thalassemia in this case, where there is a homozygous mutation. So that is why it is good to have this particular table also. This is from Hoffman or any other reference which you can find. It is good to have the age ranges for up to 2 years for hemoglobin F and hemoglobin A2. So you can see that up to 2 weeks, you can have hemoglobin F levels all the way up to 80%. That is normal. So we should be aware of this particular thing, that age is very important and transfusion history is also important. So for example, if this particular child had received a transfusion recently, there would be a large adult hemoglobin peak, which will reduce the hemoglobin F percentage. So transfusion history and age also is very important when you're diagnosing beta thalassemia major cases by HPLC. That's a third hemoglobin case, which is the sickle cell trait. Here it is very clear that there is a peak in the sickle cell window. The machine also has detected that there is an S window peak around 35%, and there are small little peaks here also, which you can see. So this is coming as 1%. So any small minor peaks less than or equal to 1%, they can be safely ignored. However, you still need to exclude a carryover or any other recent transfusion history in such small little abnormal peaks which are coming here. Another thing to note in sickle cell hemoglobin, which I mentioned earlier, that any post-translational modified products of any particular hemoglobin molecule will come before the actual peak. So here the hemoglobin, the products, that is glycated, acidylated hemoglobin, sickle cell hemoglobin is co-eluting along with hemoglobin A2, causing false elevation of hemoglobin A2. So just because there is elevation of hemoglobin A2 doesn't mean this is a compound heterozygous state. This is nothing but a sickle cell trait. This is not hemoglobin sickle cell beta thalassemia compound heterozygous state, because the patient has normal red cell indices, normal hemoglobin with this particular chromatogram. This is nothing but sickle cell trait. So how do you differentiate compound heterozygous sickle cell homozygous compound heterozygous sickle cell beta thalassemia versus a homozygous S? So this is usually done by the relative proportion of hemoglobin, adult hemoglobin A2 and hemoglobin F, as well as the CBC findings. So usually in the prevalent haplotype in Indian population is the Arab Indian haplotype. In this, hemoglobin F in homozygous state can be present all the way up to 25%. So that should not be used to diagnose compound heterozygous state. So whenever you're having a compound heterozygous state, you should look at the A2 value. So in this case, there will be high A2 along with normal, sickle cell hemoglobin and F, without any adult hemoglobin being present in these two particular cases. Moving on to another variant which is commonly seen in East India, Northeast India, which is the hemoglobin E. The thing with hemoglobin E is that in HPLC, the hemoglobin E coelutes along with the hemoglobin A2. So you cannot separate hemoglobin A2 from hemoglobin E. So that is why you have a value of 27.6. This doesn't mean that the hemoglobin A2 value is 27.6. This is both combination of hemoglobin E and hemoglobin A2. So patient will have microcytic hypochromic indices and can have normal hemoglobin. So hemoglobin E trait patients can have normal hemoglobin. So this is just a table which is denoting that most of the heterozygotes or homozygotes for hemoglobin E are asymptomatic. They usually have no anemia or mild anemia, whereas hemoglobin E becomes significant whenever it is present in compound heterozygous states along with other variants, whether there is beta thalassemia or alpha thalassemia like HPH disease heterozygous with hemoglobin E. That's when they start developing anemia. So if there is a homozygous hemoglobin E patient, so adult hemoglobin won't be present. So most of the hemoglobin will come within the A2 region. So that is one thing which you should know. So this is a representative case of a compound heterozygous state. I've put this to because this is also commonly encountered, because you have interactions between hemoglobin E and beta thalassemia. When the parents have, one parent has hemoglobin E trait and the other parent has beta thalassemia trait, the child can have the possibility of having a compound heterozygous hemoglobin E beta thalassemia. So these cases can present as thalassemia intermedia or thalassemia major depending on beta naught, and they may present with requiring transfusions or splenomegaly, growth failure, etc. So in cases of compound heterozygous hemoglobin E and beta thalassemia, the only fractions which are present are the hemoglobin E, which is co-eluting with A2, and hemoglobin F. So you don't have any adult hemoglobin in this particular case. Adult hemoglobin is 1.4%. So how do you differentiate compound heterozygous states from homozygous hemoglobin E? In compound heterozygous states, the hemoglobin E is between 40 to 60%, whereas in hemoglobin F is 30 to 60%. In homozygous E, most of them up to more than 85% is hemoglobin E, with F being usually less than 5%. So whenever hemoglobin A is present in either of these conditions, it's usually less than 10%. So the next common one with variant which is found in India is a hemoglobin D Punjab. This is common in the northern parts of the country. So I've just put both the variant 2 as well as the D10 outputs to show the difference. So as I had mentioned earlier, the D10 doesn't have a D window. So the hemoglobin D Punjab is picked up by the machine as an unknown peak, whereas in the variant 2, it is denoted in the D window. So you can see that there is 29% of this particular variant, which is hemoglobin D Punjab. So this particular case is a hemoglobin D Punjab trait or heterozygous for hemoglobin D Punjab. So heterozygous hemoglobin D Punjab as well as homozygous D Punjab, they do not have any anemia. They're usually asymptomatic. However, in this particular representative case, you can see that there is microcytic hypochromic indices. That is probably because of iron deficiency, not because of hemoglobin D Punjab. So with respect to antenatal screening, whenever any pregnant women are detected to have hemoglobin D Punjab, it is always prudent to call the partner, because hemoglobin D Punjab has interaction with sickle cell hemoglobin, so they can produce sickle cell disease. So in antenatal screening programs, if the mother has hemoglobin D Punjab trait or homozygous D Punjab, just because they are asymptomatic or have normal hemoglobin doesn't mean you should not screen the spouse. The spouse should be screened for the presence of sickle cell hemoglobin. That is the clinical relevance of hemoglobin D Punjab. Otherwise, it is a silent hemoglobin variant. Another silent hemoglobin variant which presents with microcytic hypochromic indices without major anemia is hemoglobin Lepore. So again, I have put both the outputs of D10 and the variant 2 to show you the difference. So hemoglobin Lepore is another hemoglobin variant which co-elutes with A2. So causing difficulties in interpretation. So you can see here also this co-eluting with A2. This here you can see that the baseline is not straight. So that is why it is underestimating the hemoglobin variant, which is giving us 5.3%, whereas this is properly denoted here. This is 10.8%. So hemoglobin Lepore, also similar to hemoglobin D, has interaction with hemoglobin sickle. This is relevant in terms of antenatal screening settings. The easy way to remember coelutions of clinically significant hemoglobin variants in A2 window is with this particular mnemonic. So the three relevant hemoglobin variants which coelute with hemoglobin A2 are hemoglobin Lepore, hemoglobin DE, and hemoglobin DAR. So in heterozygous states, their relative percentages are 15, 30, and 45. So Lepore will usually be less than 15%, 10 to 15%. Hemoglobin E in trait, that is heterozygous conditions, will be around 30%, and hemoglobin DRAN will be around 45%. So this is one thing which is easy to remember, this mnemonic of LED, Lepore, E, and D in the variants which coelute in hemoglobin A2. Then you have other rare conditions. You have hemoglobin H. As I had mentioned earlier, it comes in the pre-integration region, fast-moving band, and classically as a dual peak. So as you can see, there is this, which I had mentioned earlier in the differences between D10 and variant 2, the resolution is less compared to variant 2. So the peaks are not very clearly visible here, whereas here you can see the pre-integration peaks, the dual peaks, in a patient with splenomegaly, jaundice, and requiring blood transfusions. So this is a case of hemoglobin H disease. Then you have minor variants, which is hemoglobin J merit. So if you look at the chromatogram, it looks all fine. However, if you look at the P3 window, you have elevated. So the normal range is around 4%, 4 to 5%. Whereas here you can see 7.4%, here you can see 9.1% in P3. So either that there is aging of this sample or there is a variant. So if it is run from a fresh sample, this is a variant. So the variant which is detected in the P3 region is the hemoglobin J merit. This can be confirmed by other methods. Then the last uncommon variant, which is the Q India. Again, you have a very fast a band which comes the farthest away in the chromatogram, that is the small sharp peak with a low A2, that is classical of Q India, and it is here you can see that machine is not able to detect. Again, this is a sharp peak with a low A2 value. So these are clinically silent, may not be relevant in terms of the anemia perspective. So, but it's good to know that you have these uncommon variants also coming. So whenever you have any doubts so particularly in this particular case, if you are unaware of any variant which is coming in this particular region, you have the retention time. So you can go to the Biorad library of variants, input this particular retention time, which will give you an idea what particular variant might be coming in that region, and use ancillary techniques to confirm the diagnosis. So what are the methodological considerations which you should have during reporting? One is that you should check that the total area of analysis is between 1 to 3 million. Low area could be because of anemia, or increased values could be because of polycythemia. So in such cases, it is better to manually adjust the hemoglobin concentration within the sample. So it can be, you require 5 microliter sample, so that can be diluted with a buffer and loaded onto the machine. Then there can be cases where the total area is more than 100%. So this can happen. So I can show you an example. So in this particular case, if we add up all these, maybe more than 100%. So in such cases, what should be done is that you manually calculate the actual percentage. So since there might be overlapping peaks that the total area can cross 100%, so to calculate the percentages manually by taking the area of the peak dividing by the total area. Then small unknown peaks, as I mentioned earlier, anything below or less than 1% can be ignored safely. However, anything more than 1% or having unknown peaks with long retention time, this you have to pay attention. They could be transfusion transmitted or they could be carryover peaks. So all these carryover as in they are, since some amount of sample might be remaining, previous sample might be remaining within the HPLC column, there might be elution of that particular previous sample's hemoglobin variant molecule into the next sample. So whenever you're running a positive case and followed by a negative normal sample, it is, if you're getting any carryover peaks, it is better to rerun the sample. Then misidentification, as I mentioned earlier, there was that beta thalassemia major case where the F peak was misidentified because of its broad base. So it might not come within a particular assigned region. It might be shifted here or there, and it can be detected as an unknown peak. So either you can use alternative techniques or run the sample again. Pre-integration peaks, the clinically significant pre-integration peaks are hemoglobin H, BARTs, bilirubin, or acetylated F. So clinical background is relevant in this case. So bilirubin peaks are usually very sharp and thin, and you can correlate this with liver function tests. Whereas HVH peak, which I have shown in one of the cases, that there is a dual peak of low to moderate height. So this is how you differentiate with a clinically relevant history. Then you can have P2 and P3 peaks, which is nothing but post-translational peaks. That is, P2 is glycated hemoglobin. If you are detecting levels more than 6.5, it is better to alert, mention it in the report to exclude the diagnosis of diabetes, even though this is, you're not actually using this particular test to detect glycated hemoglobin. If it is present, you should mention it if it is exceeding the limit. Low P2 levels can be seen in case of reticulocytosis, so this might give you an indication of any autoimmune hemolysis or hemolysis which is happening. Elevated P3, as I mentioned, it can be because of hemoglobin J merit or age specimens. So both these considerations should be noted whenever there is high value of P3. And usually P1 is absent in normal samples. Certain limitations of HPLC. So in one of the cases I had shown, the sickle cell hemoglobin case, that in the presence of sickle cell hemoglobin, hemoglobin A2 can be falsely elevated because the adducts of the hemoglobin S can come into the hemoglobin A2 region. So that this lab should take care that not to diagnose compound heterozygous states just because there is elevation of A2. So one way to ameliorate this is by doing capillary electrophoresis, where hemoglobin A2 gets separated differently and all the glycated fractions co-migrate. So it gives a better accurate quantification of hemoglobin A2, and they're not separated like in HPLC where A0, A1 are all separated, whereas in capillary electrophoresis, all the adult fractions come in the adult region. And the major problem with HPLC is the coelution of hemoglobin E, LEPOR, and DERA. These cannot be separated and quantified. So capillary electrophoresis needs to be used in such cases. Then another issue is the fast-moving bands, such as hemoglobin BARTs and hemoglobin H eluting too quickly, coming in the pre-integration region, so you cannot quantify them. Again, these come separately in separate zones in capillary electrophoresis, so you can use capillary electrophoresis for quantification of hemoglobin H and BARTs. The other limitations is that hemoglobin A2 can be regularly underestimated in D Punjab. There is limited application of HPLC in alpha thalassemias, and the interpretation of HPLC requires skilled people compared to gel electrophoresis, and there might be high initial cost to the lab for acquiring the HPLC machine. So these are just some comparisons of the utility of capillary electrophoresis in case of the LED problem. So you can see that LEPOR is separated from hemoglobin A2, and you are getting a proper quantification. Same with hemoglobin E. These are all capillary electrophoresis outputs, where the output gives 15 zones, 15 separate zones. So much higher resolution, better quantification of coeluting variants. So this is a case where the HPLC is giving a fast moving hemoglobin BARTs and hemoglobin H along with hemoglobin constant spring. So you're not able to quantify all these in the machine is not able to quantify these particular variants. Whereas if you see here, the capillary electrophoresis is able to separate out hemoglobin H, hemoglobin BARTs, and hemoglobin constant spring, which is nothing but an alpha thalassemia alpha chain variant, and also able to give you actual quantitative values for the different particular variants. So that's another advantage of capillary electrophoresis. This is just a summary of how you should approach whenever you're suspecting any hemoglobin variants. So we should exclude the iron deficiency anemia in case of microcytic hypochromic indices, then proceed with and give a trial of iron supplements if there is low ferritin or there is any possibility of concomitant iron deficiency. Then proceed with hemoglobin HPLC or electrophoresis. And then these can be proceed further with different other ancillary techniques to detect the various hemoglobin variants. And if you are not able to pin down any particular variant, DNA analysis is the definitive method to detect novel variants or unknown variants, which ancillary techniques are not able to detect. So thank you.
So today's my talk is mastering lifestyle. I hope mastering lifestyle, healthy way or a healthy lifestyle. I call myself fitness influencer. The people call me fitness influencer because I've been, following fitness activity and been very consciously following activity since last 20 years. So let me take you through some of the important bits of it. See, you all are doctors, so you all are aware of everything what I'm going to tell you. We all know about it, but then when it comes to implementation part or execution part, we find it little tough because of our busy schedule. So let's go ahead. Let me first give a little more clarity. What is lifestyle? So that's the way we live. That's the way we lead our day. What is health and what is fitness? Though these both terms are used interchangeably, there is a slight difference. Health is like, you're being physically fit, mentally fit, but fitness is actually a task. A person who is fit may not be healthy. Like if I run a marathon, I have trained myself to run a marathon. So I'm fit to run a marathon. But that necessarily does not mean that I don't have any physical element. I can be diabetic person, I can be hypothyroid. So in a way, I'm not healthy, but I'm fit. But why these fitness thing is important? Because it's going to contribute in a very positive way to our health. So how we should plan that? Let's adopt a lifestyle which can take us closer to our fitness goal or health goals. Again, I'm saying fitness goals separately and health goals separately because, as I clarified, fitness relates to one particular task or an activity. Health is overall, health. But don't go by some rigid rules. If you follow any rigid rules, like, for example, you today decide that you want to lose 5 kg weight and you get into very aggressive intermittent fasting, you will not able to sustain it, and in fact it's going to backfire it. So please do not follow any rigid rules. So I'll try to make it very simple what rules you can follow it while being so busy in your professional life, but still, and there are some tricks you probably can use it to stay consistent. So first, before starting our fitness journey or healthy lifestyle journey, let's first remove stress. When I'm talking about stress, I'm not talking about emotional stress that we are all aware of. You know, बहुत pressure है काम का. I'm talking about biochemical stress, physical stress, and emotional stress. So what is biochemical stress? See, we are all doctors, we are from pathology. So I'm sure that you know what are preventive health checkups. I'm sure you have that in your test menu. Please get it done for yourself. I don't know how many of you have really done that for yourself, but please do it. If you really want to plan your healthy lifestyle journey, please first figure out if there is any biochemical stress. When I say biochemical stress, it could be, you know, your raise HGPT because you like having drink sometime, because your liver will be busy, handling that alcohol, and that's going to make your journey little tougher. Or it could be just like because you are a pure non-vegetarian and your uric acid level is high, your high protein you take, because somebody told you that your protein intake has to be 1 gram per body kg weight. So you are been just taking whey protein or something, and now you are dealing with uric acid, high uric acid. You're a vegetarian, your B complex, it's not sufficient. So first rule out if there is any underlying cause. Are you hypothyroid? Are you diabetics? First screen it, and you know that any of this can be easily corrected. So first remove biochemical stress. If this is not corrected, it's going to make your journey quite tougher. So I'm now considering that you are healthy, you don't have any of this, and even if you have any of these elements, you have corrected it. Second thing, some rules to follow. Again, I'm also from the same field, so I know how work-life balance is so tricky. Late nights, you come home very late. Dinner happens at 9 o'clock. So you know that you can't immediately. If there are any questions, I will take it once I finish this. Is that okay? Okay. So see what I do. I have my dinner also in my lab, and then I come home because I finish my dinner by 7:30, 8 o'clock. Nothing after 8 o'clock. So try, implementing small changes, healthy choices of food. No extreme dieting, no carbohydrates or only keto. Eat everything, but portion matters. So balanced food in moderation is a key. Physical activity, you don't have time, you have to take out time. 150 minutes in a week. If you don't have that much time, then there's a big question mark why you don't have that much time. I'm talking about only 30 minutes in a day. When like there are so many people, they tell me that we have to reach to the center by 8:30, 9 o'clock. I get up at 6 o'clock. Then I tell them get up at 5 o'clock. If you've been waking up at 5 o'clock, get up at 4 o'clock. Half an hour is not so difficult, and trust me, at 5:30, 6 o'clock, no consultant calls you for the report because they are also sleeping. So that is definitely your me time. So if you really want to do some activity, fitness activity, plan it early morning. It's your time. Hydration, I'll come to that. Adequate sleep and stress-free life. See, all these things are very, very important part of a healthy lifestyle. Though I have written, it, like this is not something which I'm giving funda. There is no rocket science. You have to follow each and everything. How do we do that? Healthy choices of food. As I said, balanced diet. When I say balanced diet, I'm talking about macronutrients as well as micronutrients. When I'm talking about macronutrients, you know that macronutrients are carbohydrates, proteins, and fats. Now, one of your friend was following keto diet and has lost weight. So you also want to try keto diet. But to understand, everything comes with its pros and cons. We all know that why carbohydrates are important. Carbohydrates are our instant source of energy. Protein is supposed to do repair maintenance job. The moment you cut down carbs, you force protein to take over. And its primary function of muscle repair, maintenance, that gets sidelined. You end up with a muscle wasting. So the ideal option is at least keep 50-60% calories coming from carbohydrate. Indian foods are the best. You have roti, sabzi, dal, rice, curd, good enough. This take care of all the proportions needed of macronutrient. Calorie deficit if needed. Again, I will give more clarity on calorie deficit in my next slides. Portion. Salads are good, but then how much portion? Even salads are coming with some calories. So portion is equally important. So keep small portion at a frequent intervals. That will help. Again, like if you like following something like a Dikshit diet, I don't know how many of you have heard of Dikshit diet. How many of you heard of Dikshit diet or a Divekar diet? There are so many Atkins diet. If that suits you, follow it, but then follow something which you can sustain it. Sustain it for a life, not for 2 months or 6 months. Time of the meal. As I said that time of meal is very important. You cannot eat food and immediately go to sleep. You need to have at least an hour or two before you go to bed, right? So time of meal is very important. किसी ने कहा है ना कि morning का breakfast has to be very rich and then meal and then evening meal has to be very lighter, right? What you shouldn't be doing, again I'll say, no fat diet. Even if somebody is getting married in 2 months time and want to lose weight, still fat diet is dangerous because you will have that whatever you have lost weight, it will bounce back again. Sugar, sweets, ideally should be avoided. See, if you take mango, 100 gram of mango will give you only 30 calories, but it's loaded with so many other nutrients also. So I will suggest go with some of these kind of a healthy options rather than going for sweets. One tablespoon sugar is like a 70 calories. So look at the proportion. So why should you torture your body? Go with the healthy options. If you cannot understand what could be healthy options, see a consultant, see a nutritionist. Probably that person can guide it better. Liquid calories. Apart from maybe buttermilk or your lime juice, not a sugar lime juice, salt wala lime juice or coconut water, I say please don't have any liquid calories. When I say no liquid calories, I'm not just talking about alcohol or aerated drink. I'm saying even no to fruit juice. Have you ever noticed that one glass of Mosambi juice takes almost 3 Mosambis or like orange juice, 3-4 oranges, which makes 1 glass of orange juice. Instead, eat that orange because you will get the fiber also and it's required. Fried food. Again, by frying the food, the water is gone and the calorie count has gone up. Stress. Please don't stress about your weight also. Because if you're stressed out that your weight is not below, you are trying to follow very healthy eating habits, but you're not losing weight. It's a different cycle. You will not lose weight. So give your body some time to understand that you are now into some journey which is going to be healthy. You will see results, but it may take some time. Physical activity. There is no shortcut. You have to. You have to invest little time in physical activity. Which physical activity? See, there are two distinct activities. One are cardiac activities, one is a strength training. Cardiac activity, where the cardiac muscle is like condition, is strengthened. What is strength training activity? The body muscle strengthening. You take the activity of your choice. You like walking, jogging, running, cycling, swimming. You like sports, do whatever you like. But understand, if you're more than if you're more than 40, 45, be little, what I should say, careful if you are choosing squash or badminton, because the movements are very unpredictable. So you might end up with a meniscal injury or a knee injury. So the safest impact of a cardiac activity is swimming. If you cannot swim, cycle. You can't cycle, go for a walk. But then don't go for a nice leisurely garden walk. You will see, like in the complex, there are people who will be walking for years and they look exactly the same, because body has taken that activity into the calculation. You need to add little intensity to your walking. So maybe like a brisk walking will be good. If you can run, just try small distances, like from this light pole to that light pole, from this car to this car, or from this tree to this tree, just small patches, 100-meter, 200-meter, and then build it. And trust me, it's a very, very enjoyable activity. You go, I mean, in the morning, you go for your walk. Maybe on third or fourth day, you will get your buddy, walking buddy or a running companion. And it's a beautiful journey. Once you started, you will hate to miss it. And as I told you, early morning time will be the best time, because that time, the professional life will not really encroach on your time. Strength training, it does have its own benefits. See, the muscle is something which is going to give you improved BMR, because that's going to burn your calories. Again, time. So I'll say that 3 days you invest into the cardio activity, 3 days you invest in a strength training activity. Again, in strength training, you don't like weight training, don't do weight training. You can do yoga if you like. Even yoga is a good strength training activities. You don't have time, do HIT, high intensity interval training. There are lots of apps are available. If you're an Android user, then there are free apps. If you're an iPhone user, then obviously there are paid apps. There's something called as a Leap Group Fitness activity. If you want, I will write it later on the chat. So download any of these apps, and it's going to give you workout for entire month. It will just take 15 minutes of yours, and that's enough for you. That's the complete activity. Just 15-20 minutes. Out of 24 hours of your day, if you cannot give 15-20 minutes to yourself, think. Hydration. See, I'm going by the rules, what I told you. What is a healthy eyesight? See, my topic is mastering lifestyle. You know everything. I'm just trying to give you how we can implement it. Hydration. You all know that adequate hydration is very, 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 very important. It's not just that it's taking nutrients from in circulation. It improves your BMR, and if you want to lose weight, hydration is very important. What happens many times, we misinterpret dehydration as hunger, and we go and eat. Whenever you feel like this, please go and drink glass of water, and then you'll realize it was actually thirst. Sometimes brain cannot interpret whether it's a thirst or a hunger. And when you feel thirsty, body is already dehydrated. So put a habit that you have to drink at a regular interval. Put that as a habit. Again, there are some apps like something called as an aqua alert. You can set it in your mobile, and every 1 hour it will give you a reminder. You drink 150 ml of water. It's not too much. In fact, put a habit that the moment you wake up in the morning, take 1 glass of lukewarm water. That's very good way to tell your body ki I'm up, activate your metabolism. And if you keep yourself hydrated, you will not have that craving, and you will not do binge eating. In a way, it's a very good way to lose weight. How much water you one should be drinking? See, if we go by the book, it is like 3.7 liter for a male adult, 2.7 liter for females. If you want to go by weight, for adult, 35 ml per kg body weight. This is how it has been calculated. If you are a sports person and if you go for a running, there are sometimes, people feel very nice. They do activity and they immediately after the workout is done, they will stand on the weighing scale to see how much weight loss has happened. Boy, that's not a weight loss, as in weight loss. That's a water loss. And you need to replace that water. So, if you sweat a lot, please check your weight before going for your physical activity. And once you finish your activity, again check your weight. For every kg weight loss, you have to replace 1.5 liter water. So as I told you, like, whatever we have calculated, 2.5 liter water for females. And if you going for a run in the morning and you have run maybe for 5-10 kilometers and you have seen 1 kg weight loss, you need to add 1.5 liter water. That's going to be adequate hydration. Clear? Sleep. Neend puri nahi hoti. That's true for all of us. But this is something, again, we have to proactively implement it. Sleep is very important because this is a time when all bodies जो maintenance वाला program है, hormone balancing, wear and tear, everything is happening in the sleep. And if you are dealing with some weight which you want to lose, sleep is very important. If you, what is the adequate sleep is 7 hours actually. If you sleep well, you will lose weight. Isn't it so nice? So for that, you need to have a time management. See, you have to understand that कि मुझे अगर 7 घंटा सोना है and मुझे अगर मेरे काम पे like I have to reach there by 9 o'clock, you don't have any option but to try and hit bed at 10 o'clock. See, I get up at 4:30 in the morning because I stay in Mumbai, and running on the road after 7 is practically impossible. So we on the road before city takes the charge of roads. So if I get up at 4:30 in the morning, even if I want to stay awake, after 9:30, 10 o'clock, I just cannot stay awake. It does not happen obviously in just a couple of days or something. This is a habit. So you have to make that as a habit. If you really feel that you need to do something, the way you look, the way you want the fitness, this is your decision. I'm just telling you the path. I'm just telling you how I could put it for myself, how I could implement for myself. What is next? Stress. I told you about this, the stress. You got to remove all the stress, biochemical stress, physical stress, emotional stress. When I was talking about physical stress, like, you go for a morning walk and you realize that shoe is not fitting you well. There is some heel pain. And then it's a chalta hai. But then what happens if there's a wrong shoes? It will not just stay to the ankle pain. The pain will go to calf, then your hip and the lower back. It will be refer pain. So it is very important. If there is any small pain, please listen to your body signals. The moment body is saying that कि मुझे दर्द हो रहा है, is asking for your attention. Give rest. Or if rest is not good enough, please see a doctor. I mean, see physiotherapist or somebody who can guide you on that. But if you're having like a severe back pain, I will not recommend you still going to the gym. Take rest. 2-3 दिन से rest से you will not gain back weight. Again, I'll say it write it somewhere in a big bold letter. 2 days workout will not give you fitness, and 2 days binging will not give you weight gain. Okay. So stress, emotional stress, see that's going to be part of our human life. कुछ चीजें अपने हिसाब से नहीं होती है, स्ट्रेस आ जाता है, but you have to deal with it. The only way to look at it with a positive attitude. Half glass empty and half glass full, both are ways, correct ways. Now, how you look at it, that's the whole thing. So count on your blessings. I know so many females, like they had a very, I mean, I've seen them going through a lot, like CA breast and then chemo and radio, and they're back to the running. I keep saying running because I'm a runner. I very regularly I run half marathons, and so I'm a part of a running community. So when I hear these stories, आपको क्या स्ट्रेस है? इतना स्ट्रेस है कि आप खुद के बारे में नहीं सोच सकते हो. You cannot adopt a lifestyle which can add life to your life. Think about it. What do you need? Money, fame, whatever. But if you don't have health in your favor, are you going to enjoy any of this? I don't think so. So attitude matters. दूसरे की साड़ी, मेरी साड़ी से उसकी साड़ी सफेद क्यों है? It doesn't help take you anywhere. So understand, this is what is available. Something which you cannot change it, just accept it. If you're still dealing with some kind of a stress, I will suggest invest at least 30 minutes into meditation and pranayama. That can really help. And again, it will be a really very important part of your healthy lifestyle. How do you monitor it? See, health can be monitored by, like, as I said, biochemical stress I was talking about. You are a diabetes, you're monitoring it. Now your HbA1c is controlled. Your non-HDL cholesterol was high. Now it is in control. Uric acid was high. Now it is in control. Yes, you're monitoring it. How we gauge fitness? We gauge fitness like, earlier you couldn't really do chakrasan. Now you're able to do chakrasan. So now you're fit to do chakrasan or a halasan. I'm talking about yoga. But otherwise, the good health parameters will be fat percentage, body fat percentage. How you calculate body fat percentage? Again, some apps are available. So you download some apps from Android phones. Make milega aapko body composition, body fat percentage. It takes your weight, height, neck circumference, waist circumference, and hip circumference, and that will be a good tool to monitor. If that you find tricky, then the best thing is just get a weighing scale and stand on a weighing scale. But that's a very rough tool, and sometimes it is tricky. If you do weight training, you're going to gain little weight, and then you should not be really worried that your weight is going up, because that's a healthy weight, right? If you been starving, you are dehydrated, your weight will be seen low, but that's not a healthy way to lose weight. But then it's an easy tool to manage. And then there are so many other things like, body mass index, then there's waist hip ratio. You take any of these tools to monitor your health, but monitor it. So, things which gets measured gets done. So do it. Sorry, I'm like, I'm talking about health and I'm talking health fitness, and then I'm talking about a weight loss. I'm talking about a weight loss because that's going to be a healthy lifestyle. If you're in a perfect weight, you're closer to your target weight, you are doing super. But if you are dealing with little extra weight, here is a trick. So today's body weight is a result of what you eat and what you burn. Simple. And if your weight is constant, maybe since last 3 years or 4 years, this balance is going on perfect. Whatever you are consuming, your body is able to burn it. If you consume more and body is not able to use it, obviously there is a weight gain. Now, if you want to lose weight, whatever you consume, you got to burn more. If that's going to be tough, then you got to be smart in this calculation. So what is going to be important in this case is a calorie deficit. What is a calorie deficit? So you eat nutrient dense food rather than calorie dense food. When I say nutrient dense food, that means I'm talking about a really healthy food, like, all green vegetables, maybe eggs or a dairy, some good cereals or legumes and pulses. These I'm considering as a good food, good nutriting value food. Calorie dense food is all your junk foods, or sweets. These are all calorie dense foods. So limit your calorie intake, burn little extra calories. How you can do that? If you've been walking at little intensity, like I said, like do brisk walking, so you will burn more calories. You've been doing brisk walking, start running. If you already been running, then you can increase the pace. I mean, improve the pace. Create 3,500 calorie deficit. I'm not talking this 3,500 calorie deficit in a day or 2 days. Whenever you have the 3,500 calorie deficit, it can promise you 500 gram weight loss. In fact, actually it is 1 pound. So it comes to something like 454 grams to be specific. So every day, if you can create, let's say, 350 gram deficit, how? Like today, if your meal portion size is giving you 2,000 calories, you smartly plan it to 1,800 calories. So you got 200 calories deficit there. You were not doing any activity. Now you started walking and you have started walking for 30 minutes. So you're burning, let's say, 150 calories. So I got 150 calories from there. So this is 350 calorie deficit in a day. Now over a period of 10 days, it will be 3,500 calorie deficit. This way, if you go 100%, you will lose 500 grams. If you do something and if you're not losing weight, that means you're not into calorie deficit. The spirit, that's it. Now, there are some tips, very fast one, quick ones. You want to adopt healthy eating, but होता नहीं है. Party होती है शाम को, दोस्त के घर पे party है, college reunion hai. People will be very upset if I don't eat. This is what I do. You see if this sounds good to you. It's very difficult, but this needs some kind of a determination. Like, ye pagalpan hai. Fitness is pagalpan. Like, some rules, you don't want to break it. And when you get up at 4:30 in the morning and you run for 1.5 hours and you see that you have burned 300 calories, 300 calories, मतलब एक chocolate cake मैं खा ही नहीं सकती हूँ. Because the moment I see the chocolate cake, it comes to me that oh my God, मेरा सुबह की सब मेहनत पानी में चले गए. You can find this very crazy, but you got to get into my shoes to understand what I'm talking about. So please avoid eating outside. Once in a while is okay, but it cannot be a regular affair. Interesting healthy meal option, yes. See, like I tell you, I go for my morning run. So what I do, my pre-workout meal is like a sweet potato chat. So what I do, I take boil sweet potato, I smash it, I add little groundnut, I add little curd, and I put pomegranate, that dana, and I make nice chat and I sit and enjoy it. So how the food looks to you, that also makes difference. Healthy food need not be boring food. How you put it in well, the presentation part, that equally matters. And खाना खाने का भी style होता है. Like I feel that you should respect food. Till date, I sit on the floor. Okay, you want to sit on a dining table, please continue doing that. I'm just telling you how I do it. This is my way of making it work for me. It has worked for me. I sit on the floor when I'm eating my food. The TV is not on, my mobile is not on. My 10 minutes are totally for my meal. I'm grateful to God that God has given me such a lovely meal. It's going to give me energy for the entire day. So I have that utmost gratitude for the meal, what is in front of me. Try it sometimes and you will know how it feels. So please eating avoid outside. And अगर कुछ पार्टी के लिए जाना है तो प्लीज घर से पहले कुछ खा के जाओ. So that there will not be that कि कुछ चीज अच्छी लगी करके you binge. Cheat day, okay, you want to have cheat day, please have it, but then you cannot have a, have you heard of this John Abraham? Apparently last 25-30 years he has never cheated. Salute to him. I sometimes cheat, yes, but try not to if it is possible. And if you want to, then eat something what you like, but then portion it. If you like having 2 gulab jamun, now just stay with 1 gulab jamun. Good to go. Intermittent fasting, again, this is kind of a fad diet, but for some people it really works. I mean, there are lots of ways to do it. This is one of the most popular way, 16-18, 16-8. So people don't eat for 16 hours and they have a window for eating 8 hours window. So like you have last meal at 8 o'clock in the evening, and the first meal of the day, they have it at 12 o'clock in the afternoon. It works for some people fantastically. Again, I'll say it is nothing but a calorie deficit, because when you're doing this, you're skipping a meal. Our Indian style of eating, we normally have 3 major meals, right? Morning breakfast, heavy breakfast, then we have lunch, and then we have dinner. So with this kind of intermittent fasting, you have just skipped your morning breakfast. If you're not able to plan your meals well, like what I was talking about, high nutritive value meals, if you're not able to plan it well, this could be easy tool for you. Remove junk, and as I told you, अगर खाने को कुछ अच्छा मन करता है, तो tell yourself that rewards will come after performance. I will adopt this healthy eating for a week, and then weekend I'll have this. So reward should come after performance, not before. अरे कल से ना मुझे डाइट शुरू करना है. आज ना डॉक्टर अपर्णा ने मेरे को बहुत अच्छा से समझाया. मैं ना अभी कल से मेरा हेल्दी जर्नी शुरू. आज मेरे को अच्छे से खाना है. It doesn't happen that way. You have to start your healthy fitness journey today. Put it at least into more movement for at least 6-7 days, and then do whatever cheating you want to do. This is the way it can work. Now, secrets to regular exercise motivation. She set goals which are realistic goals. Like मुझे लगता है कि मैंने वजन लूज करना चाहिए. मुझे लगता है 1 महीने में ना 5 किलो तो मेरे को घटाना ही घटाना है. Please, that's not going to be a healthier way to lose weight. जो चीज 20 साल से पाली है, उसको ऐसे 1 महीने में घटाना है. Give yourself some time. Be a little realistic. Maybe you can try and lose 1 kg. That's a healthier way to do it. Do it slowly, but stay with it. So be specific, be measurable and time bound. जो भी कुछ करना है, जो भी गोल्स आपके लिए सेट करने हैं, that has to be time bound. कि मेरे को 3 महीने का पीरियड चाहिए, 3 महीने में मैं ये करूंगा, ये तो मैं ये करूंगी. आउटकम एंड प्रोसेस गोल. आउटकम डिसाइड करके रखो कि मुझे ये जर्नी में जाना है. दिस इज द आउटफिट आई हैव टू फिट परफेक्टली. ओके. प्रोसेस गोल्स आर लाइक प्लान इट कि कल मैं योगा करूंगा, डे आफ्टर टुमारो आई विल गो फॉर वॉक, आफ्टर दैट डे आई विल गो फॉर माय ट्रेकिंग. Plan your activity, plan it well in advance. So if you are really serious about it, it will need some kind of a planning also. It will, please do that. Identify enjoyable exercise activity. As I told you earlier, मैंने बोला करके आपने अगर एक एक्टिविटी शुरू की, you will not be able to continue it. बोर हो जाएगी आपको वो एक्टिविटी. मैंने बोला कि आप योगा करो, आप योगा शुरू करोगे, बट यू आर नॉट एबल टू एंजॉय योगा. एक 8-10 दिन में ही आपके पास में 50 एक्सक्यूजेस रहेंगे. अरे नहीं, मेरा ना बैक दुख रहा था, ये आसन मेरा बॉडी ऐसा फ्लेक्सिबल ही नहीं है. 1000 things will come. So do what you feel you are enjoying it, because then you will stay with that activity. Please look for a workout buddy. Like I told you that HRT, Leap Group Fitness workout, this is something which you can do at home and you really don't need any equipment. You can do with your partner. Like you can ask your husband to join or wife to join. It is a nice partner time, and it has got a cue also. Record it. It will feel nice. You can check your form also. Rewards, like you say that कि मैंने अगर 1 महीना वॉकिंग सीरियसली किया, लाइक 1 महीने में मुझे 100 किलोमीटर्स वॉक करना है. Forget it, 100 kilometers may sound big number to you. Let's say 50 kilometers walk करना है. अच्छा, how do you calculate this? How much your work? Again, please download some app which can monitor your work. You can download Runkeeper or you can download Strava. Any, like Apple has its own app. Please download that app, and whenever you go for a walk, please monitor it. See, I'm wearing this watch. This is my smartwatch. This is my Garmin. Like I'm a total style bin, but this Garmin watch doesn't go from my hand. I want to monitor what I do. So invest into a smartwatch. If you don't want to invest in a smartwatch, at least record your activity on your smartphone. And then reward yourself. कि मैंने 50 किलोमीटर इस महीने किया, so now I'll buy new t-shirt. Something like this. Fitness challenges. Okay, now this is something may interest you. See, I've been motivating lots of people. अकेले हर दिन वॉक के लिए जाना कभी कभी बोर हो जाता है. So I have a group, like one girls group. I call them as a power girls group. Then there's a soulmates group. Okay, there are boys and girls are there, and they're from a different profession, from different part of India. So I gave them fitness challenges. For example, in April month, I had given them challenge: lose 2 or risk 500. Okay. See, this kind of a challenges, probably you can set it in your group. Like, I'm sure that you have a family group, WhatsApp group, family number 1, Hatke family, or, तुम्हारा buddies का group रहेगा. Rather than doing that, hello, hi, hello, how are you, morning में, आपके कुछ तो forward messages, put this group in a good use. How you can do it? I'll give you an example. So in this group, what I did, I told them that you have to pay me $500. So everybody paid me $500. So they took a challenge. Everybody wanted to lose 2 kg weight. Obviously, they had that much weight to lose. Please, if you're at a weight of 50 kg, don't get into that kind of a challenge. Be little realistic. So I gave them a cardio challenge and a HIT challenge. So for 1 kilometer walk, they got 1 point. For 4 kilometers cycle, 1 point. And 1 kilometer swim was 10 points. Okay. If you want, I will share that later. I can share how exactly that challenge was set. And then HIT challenge. So any activity, you do yoga or you do power yoga or you do Zumba, you do the activity, you say that ki, I did this activity, you score 5 points. But you, if you record that activity and share, then you get 10 points. The challenge was to like from that group I know everyone, so I know everybody's fitness level. So it was not that ki everybody had to had a similar target. So let's say Amit had 100 cardio point challenge and let's say 50 HIT challenge. So now what I did, they had to do the activity and share that on the group, even that HIT. So people shared their yoga videos, people shared their dance videos, and it was a beautiful energy on the group. What I told him, if you lose 2 kg as you are committed, I refund that 500 rupees back to your account. And if you give me those cardio points and that HIT points, I will reward you with 100 points. And it really worked very well. 80% of my group lost weight. In fact, this game has continued. We continued in May, little different format. What I'm trying to tell you that you want to see, you know what is healthy lifestyle. मैंने जितनी भी चीजें बताई, you knew everything. You somehow didn't know how to execute it. I'm just giving you tools which worked for me, for my close buddies. Probably, if you're serious, you can plan something like this for your group. If you want my guidance, I can help you how to design it for your group. But it can work. So, yes, fitness is never-ending journey, or like a healthy lifestyle. ये 2 महीने का कार्यक्रम तो है नहीं. This is going to be journey. Why I said fitness is a never-ending journey. Like today, you want to run half marathon, or rather, 10 kilometer. Once you run 10 kilometer, you want to try half marathon. Once you do half marathon, you want to shift to full marathon. Once you do full marathon, you want to do ultra. Once you're done with ultra, you want to do 100 kilometers. Once you're done with 100, you want to do 100 miles. Your destination will keep changing, but that will keep it interesting too. It is possible only if you set yourself as your priority. As a human being, we cannot give justice to more than 2 or 3 priorities. I understand we have lots of work pressure. Life is very, very, very demanding. But finally, खुद के लिए अगर कुछ नहीं किया तो क्या किया? Just put yourself as your priority. Once you put yourself as a priority, you will be able to take out some time for yourself and adopt all the habits which can called as a healthy habits. These add life to the days. So these are apps ke funde. I write sometimes some short blogs and I write it as apps ke funde. So that's about it. Lage raho. Take charge of your life and style it your own way. Thank you so much.